So thanks so much. My name's Ian. I'm a reader in rheumatology and a consultant rheumatologist working at Keele and Stoke. And today I'm going to build on what Jonathan's been talking about around using electronic health record data to improve the care of people with inflammatory arthritis managed locally within our NHS trust. We'll all be familiar with the NHS 10-year plan, and one of the key shifts is from analog to digital. And this is therefore unavoidable for clinical services, but it's a real opportunity to embrace this change and help shape it to improve patient care. However, within electronic health records at our trust, we had a couple of challenges. The first was the fact that data was stored free text in letters as words, not as numbers, as coded data or outcome measures. And this was really brought home to me by a service evaluation that we did, led on by Dr. Tarrar, where we were interested to see how many consultations or what proportion of or percent of the consultations during the pandemic that we saw subsequently needed to be seen face to face. And we looked at the letters of around 500 consultations. And as you can see from the bar chart, of the new appointments, around 60% of people that had a remote consultation had to be seen for an examination, a lot less of follow-up. But the problem was that the data was largely free text in notes, and it took a team of about 6 of us about 6 weeks to get this very simple data. The second challenge is one of measurement. William Thompson, a 19th century statistician, also known as Lord Kelvin, has this quote that if you cannot measure it, you cannot improve it. And I feel very strongly that that's the case. And more recently in rheumatology, Professor Werner Wright had this quote that clinicians spend years writing doing well in the notes of a patient who's become progressively disabled before their eyes. So I'm quite zealot around capturing outcomes from people, and people with inflammatory arthritis, it's very important that we do capture outcomes, something called disease activity, because people can be quite uncomplaining, can have some grumbling inflammation, and if we don't get on top of that with immunosuppressive drugs, the outcome's a lot worse. And our solution at a trust at which I work at, which is MPFT, is we developed a new electronic health record database that allowed us to capture coded data and also data on outcome measures. And there's 2 complementary systems. The first is the Haywood Arthritis portal. It can be accessed here. Anyone with internet connection can access it, but you can only register if you're under our care. And it collects electronic patient reported outcome measures, which are validated questionnaires gaining patients' perspectives on their health. Patients can also view the data they enter. This is then fed forward to the clinician's face called the Haywood Rheumatology portal. Clinicians can see it. They can also enter their own assessments of outcomes for patients, such as their own disease activity assessments. And also for each consultation, we enter information about the diagnosis, the treatment, referrals and tests that we've done. So we've gone from having information that's very hard to get from free text in letters towards having everything very much at the tip of our fingers. And this electronic health record combines 2 key ideas. The first is the importance of capturing patient-reported outcome measures to enable holistic care and to give patients their voices. And the second is to capture information entered by clinical teams to get clinicians' perspectives on their health and also better understand healthcare use. In terms of the development, in 2019, we were awarded some funding from the Haywood Foundation, our local charity for people with arthritis, to develop it. We did a stakeholder workshop, including a patient, developed a prototype, did informal usability testing with patients, and then we did a phased implementation since 2021. So it's been in use for around 5 years. And we focused initially on inflammatory arthritis to the patient interface, because it's common. It affects over 1% of adults in England, but importantly accounts for around half of rheumatology outpatient activity. So it's very much the bread and butter of what we see in rheumatology departments. There's many validated patient-reported outcome measures for people with inflammatory arthritis, and there's massive costs both individually and to the NHS if we undertreat it. And targeting what we call low disease activity or remission from your arthritis is felt to be really key to optimizing people's health and outcomes. But it's very much a proof of concept, and my wish is that we extend it to other conditions moving forward. I'm not showing you any patient data. This is all simulated data, but this is to give you a bit of a taste for what the interfaces look like. So at the top, this is the Haywood Arthritis portal. This is someone that said they've got rheumatoid arthritis. It allows them to enter their tender joints in their hands, so they can enter on a mannequin how many tender joints they have, and also their swollen joints. And we've got videos and information in there to show people how to do that. So that's just one example of the outcome that it captures. And then that information is then fed forward and displayed for the clinician. So you can see on here, someone's got, I think, is it 4 tender, 4 swollen joints? But it also captures a lot of other outcomes. So their pain, their function, their health, and it's displayed in a dashboard, highlighting problem areas. Ed doesn't see anything. Can everyone else see what I'm doing?
I can see. Yeah.
Yep.
Okay.
Yeah. Yeah. Okay.
Sorry, Ed, but the slides will be online, I think. So before patients actually enter the consultation room, if this has happened, I know exactly how they feel they're doing. I know exactly the aspects of their health that they're struggling with, and we can really focus on those. But that's just the one consultation. But outcomes over time are where the power for me particularly lies. Again, simulated data. In this example, we've got tabulated, which I as a clinician would see this information. And I can see that in this person, they've got persistently high tender joints and swollen joints, moderate disability and low quality of life. And clearly we've got to change tack. We've got to do something different. We're not winning there. In terms of how the Haywood Arthritis portal is implemented for patients to complete, people are seen on dedicated inflammatory arthritis clinics in our service, and a lot of other rheumatology services do the same. Those with a registered phone get sent a text with some information about it and a link, and everyone gets an appointment letter with some information and a QR code. People with internet access can self-register and complete an entry on their own device, and it can be a smartphone, it could be a computer, it could be a tablet, just not a smartwatch. And those without internet access are invited to complete something on a tablet in clinic when they're waiting, with support from one of our healthcare support workers. And that's a short version that takes a few minutes to complete and pass the time while you're waiting to see the clinician. And that information is then viewed by the clinician that sees them. And I think it's important to understand what patients think of this process. So we've tried to involve as much as possible in the design of it and the rollout. Natasha Cox has led on a mixed method study funded by the British Society for Rheumatology and NIHR, where we've surveyed and done some interviews in people completing it. This is a survey of 336 patients, and we asked them about the acceptability. And that's very much a multi-dimensional aspect, but one of it was the global acceptability. So how acceptable they think it is to complete and answer online questions about their health. And at the top, we've got this Likert scale presentation, and you can see that in all people, around 90% found it completely acceptable or acceptable. And it was similar in people doing it at home or in clinic. But we also looked at how this varies by patient characteristics, and we found that the biggest factor was someone's digital skills. So there is the Lloyds Bank Digital Foundation Status Framework. I don't know how familiar everyone is, but it's requiring all the skills to access and independently navigate the internet. And if you have those, you have foundation status. And if you have foundation status, the majority of people find it highly acceptable. However, those people that don't have all of it found it less acceptable. And if you lack any of those skills and what we call digitally excluded, even less so. So having those digital skills is really important to the acceptability of answering online questions. The other area of particular interest to me as a rheumatology is how good patients are assessing their own disease activity compared with the clinician assessing their disease activity. So I guess it's not how good, but what the level of agreement is, because the nice guidelines for rheumatoid arthritis is that what we should do is measure their disease activity and increase their treatments until we achieve at least low disease activity. And patients are able to do this themselves at home. And the main score that we tend to use is something called the DAS28 CRP. It takes information on how many tender and swollen joints a person has, and it combines them with their inflammatory markers and how active overall they feel that arthritis is into this composite score that ranges from around 1 to 8. And the scatter plot on the left of this graph shows on the x-axis the clinician assessment of disease activity, and on the y the patient. Sorry, that's the other way around. But you can see that they're clearly strongly correlated with a R value of 0.67. And in terms of agreement, this tabulation table on the right shows the proportion of patients that rate themselves an inactive that the clinicians also rate their arthritis inactive. And you can see that around 84% of people that say that arthritis is inactive, the clinician agrees. But the agreement is less of people that say that arthritis is active. So a third of people that say it's active will also be inactive. But overall, I think that this shows that patients and clinicians largely have similar views on disease activity, and particularly important, if a patient says their disease is inactive, it's likely to be inactive when assessed by the clinician. So on to the next steps. We've had consultation information entered in around 61,000 consultations, and we have the portal being used by patients just around 5,000 times, but clearly uptake needs to be improved, and we're working to improve that. There's always in the NHS some technical difficulties around implementing complex processes like this. We want to refine the system based on the feedback we've got from patients and users in our mixed method study. We want to extend it to other conditions. We're conducting further research following obtaining HRA approvals to do answer specific questions using anonymized data. But most importantly and excitingly is I want to use the data and the system to improve the care that our local patients receive. One example is supporting so-called patient-initiated follow-up. People that are doing well with rheumatoid arthritis, they don't need to come up and see us all the time. They can contact us when they need to be seen and come up. But it could be quite a few years between people potentially contacting and being seen, and the portal could be used to understand and keep a track on them in the meantime and bring them up if their disease is becoming more active. We could use it to triage waiting lists. We've got some people that are waiting quite a long time to be seen. We could send them the portal, they could complete it, and we can triage and see based on urgency of need. But what I'm particularly passionate about is understanding care, understanding what we're doing, and trying to unpick whether or not there's ways in which the service could be improved to better help our local population. So in conclusion, we've developed a new, robust, secure NHS system that integrates electronic patient-reported outcome measures and other coded electronic health record data. I think it's particularly important to ensure digital inclusivity. This shift, widespread almost overnight, to you doing things online, risks leaving people behind, and we've got to make sure processes in place to prevent that. But I think there's so many benefits to having coded electronic health record data, not just for the individual consultation, but also the bigger service and understanding things at a population level. So thank you very much for listening. I'd just like to acknowledge everyone in this slide. No work's done alone, and everyone's been really important in rolling out this process and understanding the data. The Haywood Foundation for funding it, MPFT Digital Services, all of my colleagues in the rheumatology team and the researchers, the patients, the National Irish Society and the funders. So thank you ever so much for listening.